we're now going to hear from Dr. Bianca Frogner.
Thank you so much for having me here today. I'm honored to join this panel and the broader workshop, which has been a really interesting and engaging workshop. So congratulations to the organizers and the roundtable for pulling together this informative session. So again, my name is Bianca Frogner. I'm a professor in the Department of Family Medicine. I actually am a PhD public health person in an area of health economics. And I am sitting in the School of Medicine at University of Washington, where I direct the Center for Health Workforce Studies, which is where that is housed and has been housed for the last 20 years. Before I get started, I did want to at least acknowledge a couple sources of funding that is informing the work today, and just mention the fact that I am the PI of 2 grants from the Health Resources and Services Administration, which do focus on health workforce research, as well as I've been a PI recently of a grant from the Siemens Foundation that will be informing some of the work today. And also the work that I'm going to talk about has been done collaboratively with other folks in my center, including Sue Skillman, Grace Gunther, Cindy Snyder, and Davis Patterson. And of course, anything that I present today does not represent the views of the federal government. Now, I've seen many great frameworks today, so just take this as a grain of salt that this is just a working point to help center the conversation that I plan to have today with you all. I'm going to focus a little bit more on those who work a little bit more in the traditional healthcare settings, and maybe traditional isn't the best word, but the idea is those who may be working a little bit more on the medical side, or whether it be hospitals, ambulatory care, or long-term care, and how that might relate to those who work more in community settings. Because there has been a lot of talk about the public health workforce, but there are many folks that have been acknowledged throughout the day that work in these other settings that are also delivering public health care, as well as the broader set of caring about the population. And I think it was Dr. Sharfstein who mentioned earlier today that there are people who work in the population health workforce who actively know that they're doing so. And then there are many of those who are not maybe as aware that they are part of this population health workforce addressing issues of population health. And I think there are opportunities here for us to create greater awareness about their role and in addressing population health, and for us to acknowledge that there are many types of workers that may be addressing these issues. And I think, as it's been mentioned in other presentations throughout the day, within the healthcare industry, whether it be hospitals, ambulatory care, et cetera, many of those settings are starting to recognize the importance of population health and are investing in initiatives to address their community that they serve to some degree. And so they're hiring folks who are playing these leadership roles and probably hopefully staffing their teams with those who have a public health background, but also folks who have a variety of other training and experiences. And then there are those who are working in the community, working with populations that are in most need of high quality health care, but also could use some social services to improve their health, but also maybe working for other parts of addressing population health, such as working in the sanitation arena, thinking about climate change. And so we have many of those folks in the community who are doing this work towards improving population health. And increasingly, there's an interface between what's happening in the community and what's happening in these kind of more traditional healthcare settings. And it is this intersection that I would maybe arguably call the population part of the population health workforce, and that there's an increasing overlap. So this is just one kind of basic framework to help think a little bit about the comments I'm making today. And what I want to highlight in my talk are 3 major categories of healthcare workers that may be part of the population health workforce to better unpack these groups. So one group I'm going to start with is a clinical lab workforce, which has been mentioned several times throughout the day and has been identified as a group that's clearly helping to support the population health workforce, if not part of it entirely. Also, I'm going to touch on the behavioral health workforce, as well as the workforce that may be residing in safety net clinics, such as federally qualified health centers. So my colleagues and I, with funding through the Siemens Foundation, work together with the American Society of Clinical Pathologists to unpack the clinical lab workforce. And I think a key point really about the clinical lab workforce is that there are many, many careers under this umbrella. And we just took a look more carefully at 6 particular occupations. These were chosen just to get a sense of variety in job titles, in roles, as well as a variety in education and the pathways to these positions. And these are ones that you may be familiar with. For example, if you have your blood drawn, then most likely you've encountered someone who may be a phlebotomist. Those who are in the labs actually processing and interpreting the results of your test results, including your COVID tests, could be your medical lab technicians or medical labs, or probably more likely your medical lab scientists. And so one of the key things that actually really came out of this report, in addition to identifying the fact that there are many careers, is that there's actually a bit of a lack of consistency in the titles used in this workforce. For example, here in this report, we use the term medical lab scientists or medical lab technicians or medical lab assistants, but many others may also see these as terms such as clinical lab positions. So when I just know that when I'm mentioning this, this is really just being used interchangeably. But this is something that the field is starting to recognize, that there's a need to better unpack these different titles. And the key thing about, again, these occupations is that there are many opportunities to get into these jobs. There's a variety of educational pathways into these occupations. Now, there's a lot of detail here, and I encourage you to read the report to learn more. But for example, histotechnologists, their pathways into this position can be just directly starting with a 4-year program, but or also they can have some prior clinical lab experience or training that they add some more specific training onto. So an advantage of this field is the variety of pathways to get to these occupations, and that there are a range of opportunities ranging from less than a year of post-secondary education to multiple years of education. Another area of the health workforce, population health workforce, is the behavioral health workforce. And this is just a slide that kind of indicates the combination of workers you may need to have on the team to address different levels of physical health versus behavioral health conditions, where the lower left quadrant indicates those with low levels of physical health and low levels of behavioral health needs. And the quadrant to the right is going to indicate higher levels of physical health. Going up the y-axis is higher level of behavioral health risk. And the key point here is that as you increase complexity of needs in both physical health or behavioral health needs, you see an increasing number of providers that are needed to support these types of patients. And what you see emerging are a number of workers who are really residing in the community and not only residing within the hospital or ambulatory care settings, such as you need community supports. I saw someone mention earlier, how about the role of community paramedics? This is a perfect example of where community paramedics, those who work in the field, could do more than transporting patients from their home to clinical settings, but could actually provide treatment within the home. Within federally qualified health centers, we see that this type of a setting can employ many different kinds of providers. And this is data that comes from the Uniform Data System, which is an administrative data set of FQHCs, just to identify the fact that you can find a large range of health professions, as well as social care professions working all together in one setting. And this just gives you a sense of the distribution of the types of workers that we may see within FQHCs. And I just picked a smattering of them that might be particularly key. For example, we have about 1% of FQHCs FTEs dedicated to lab professions. We may also see within FQHCs about 4% of the FTEs dedicated to case management, another approximately 4% focused on providing outreach or patient education or community health work. Now, this is just at a high level at the national view about what percent of total FTE is dedicated to these different professions. But what is not shown and needs more work is for us to understand the fact that FQHCs may vary in terms of the combination of professions that may be within a setting, and that there may be quite a bit of variability in FTE within any one setting that is dependent on funding. And that is something that needs to be explored a bit more to understand which populations may actually have access to these different kinds of workers. Now, there are many, many challenges that are facing the population health workforce broadly, and those that cross all the professions that I'm mentioning today and have been touched on in others' presentations. One is the lack of visibility of the career opportunities. This was really obvious for the clinical lab workforce work that we've done, but I think is coming across, I think, throughout the day, which is when folks are looking for a career, it may not always be so obvious that these are population health workforce opportunities, and that there are many occupations embedded within the concepts of clinical lab workforce or within the concept of the behavioral health workforce. And we need to help individuals understand that early on in that K through 12 time period, but also throughout people's careers, that there are opportunities to move up career pathways, which gets me to the second point of some common challenges, which is the lack of career pathways to a particular job, but then also beyond. There's a lot of work that we still need to do within the population health workforce, but also across the healthcare workforce generally, is to link credentials that people are getting to potential future jobs in the future. And to help people get there, we need to also figure out how to financially support people to get there. Because for many folks to say, just go ahead and get a college degree and there are many opportunities there, that can be really difficult for those who may be coming from a family where they're a first-time college attendee, let alone graduate. So we need to make sure that people have the financial resources to be able to do that, whether that be through loan repayment or perhaps it's through fellowships or grants that are given up front, as well as providing on-the-job training. And lastly, I think another key issue that we need to think about in terms of improving our career pathways for those into the population health workforce is acknowledging the fact that we already have a fairly fragmented healthcare and social care system, and that we're trying to sort out our financial reimbursement systems that even reward our healthcare system to think about population health. And there is an increasing investment, again, by more traditional healthcare settings to invest in population health, but we need to help folks not duplicate too much of the efforts and work together in concert. So I'll stop there and happy to answer any questions.
Terrific. Thank you, Dr. Frogner. Appreciate your remarks, and we will have time for questions at the end.